Thank you very much, and thanks to the organisers for the invitation to participate in this rather remarkable talk fest. Not something that I usually do. I want today to make the case in defence of a rather old-fashioned discipline of which I've been an exponent for a long time. It's the discipline of cognitive neuropsychology, which is a very particular way of investigating what happens to cognition when the brain becomes damaged, and that's a way of thinking about how the normal brain functions. So the discipline begins with these two chaps. That's Paul Broca here and Carl Wernicke, whose names you might know, pictured here respectively with the brain of the patient in each case, around which their fame revolves. They were working in the 1860s and later, and what they both did was to present a patient with a very particular kind of language disorder. So in the case of Broca's patient, a patient with a lesion to the front part of the brain who became unable to speak except to say a couple of syllables like tan and some swear words, but who was able to understand what was said to him. And in the case of Wernicke's patient, a patient with a more posterior, that is to say a lesion further to the back of the brain, who became unable to understand anything that was said to him, although he was able to speak, not always meaningfully for sure, but was able to produce words. Out of their investigations with these two patients and a few patients like them, a model of language function in the brain developed, which actually remained the model with which we all worked until quite recently, until the last 20 or 30 years, I would say. It's a model which represents the lesions of the two patients. So here is something that became known as Broca's area. In the front part of the brain, very closely allied to this, which is the motor cortex, the region thought to be responsible for our ability to produce speech. Wernicke's area, a region in this posterior region of the temporal cortex, thought to be responsible for our ability to understand spoken speech, and this fibre bundle that runs between them, a rather simple map of language function in the brain. More recently, over the last 20 or 30 years, somewhat to do with the investigation of patients, which I'm going to talk about more in a while, but also to do with the development of technology, MRI, PET imaging, tractography, a rather more complex mapping of language function in the brain has evolved. Don't pay any attention to these rather technical terms at the top, but what I want you to just look at is the way that the mapping has extended now into a quite complex network around the frontal lobe, the temporal lobe, the region known as Wernicke's area, but also including other parts of the temporal lobe, and extending also into the right hemisphere of the brain. So it's a much more elaborate network than we were accustomed to thinking of. And the language representation is largely thought of now as comprising two different processing streams, analogous to the two streams that are thought to underpin visual processing in vision for space and for definition of perception of what you're seeing. In language, a dorsal stream that's involved to do with the translation of auditory speech signals into acoustic, articulatory, rather representations for spoken production, and a ventral stream, which is to do with the processing of speech for comprehension, but which is also very strongly connected with a region of the brain thought to be responsible for the housing of or the mediation of meaning as such. So the sort of repository of semantic and conceptual knowledge of the brain. So here we have the dorsal stream, responsible for this processing of acoustic information, and here a ventral stream linked to the auditory cortex, so responsible somewhat for the processing of incoming speech, but also linked to these regions which are more to do with the housing of semantic knowledge as such. Now, for a very long time, all that we knew about aphasia was based on stroke patients, and there was a very good reason for that. This is the left hemisphere of the brain, and this is a region, an arterial territory, a system of blood vessels known as the middle cerebral artery, which is very liable to be affected by stroke, and which is the system of vasculature that actually nourishes a large number of those regions that we've just been looking at. So it's not surprising that patients who have strokes to some part of this territory end up with a form of aphasia. Here are some representations of that. Here, these white areas represent hemorrhage in the more anterior part of the middle cerebral artery terrain. Here, the dark area represents a blockage of blood supply and therefore loss of tissue to that region. Now, one of the things about stroke, though, is that it's quite a difficult phenomenon to study. Patients vary enormously in both the location and the extent of their lesions. They might have difficulty with expressing themselves, they might have difficulty with understanding what's said to them, they might have difficulty with both, which we call a global aphasia. But there's just not a lot of consistency from patient to patient. So although we know that someone who gets a stroke to the middle cerebral artery is likely to have problem with language, we're not able to predict very well what the characteristics of their difficulty will be. They perform inconsistently on different tasks. They might do better at writing than at speaking, for example. They make inconsistent errors, both one patient tested from one time to another and between patients. There's no pattern to the errors. There's no particular sensitivity to the kinds of words or ideas that give them difficulty. And most importantly, for what I want to talk about now, is that when they are naming things, if they have difficulty with the name, they might be very well helped if you give them the first letter or sound of the word, which indicates to us that their knowledge of the word and the word meaning is still present, but that the difficulty they're having is difficulty in accessing it. Now, it turns out that, I'm just going to go back a moment, it turns out that this region of the brain largely affects the dorsal processing language system. So it largely affects this region here, including a little bit, somewhat, this most posterior region of the ventral stream. What then about this area here? It turns out that it's rather impervious to stroke, perhaps because it's nourished by more than one arterial territory. It's not quite clear, but it's an area that's very rarely damaged in stroke. And so it wasn't until a quite different kind of patient began to be noticed and described, starting actually at the National Hospital here in the 1970s, but investigated much more intensively more recently. Patients who have not stroke, but who have a neurodegenerative condition, not unlike Alzheimer's disease, but not Alzheimer's disease. It's known as semantic dementia, and it selectively affects the anterior temporal lobes, the region that we were just looking at on that map. So if you look at this, this is like a region through the brain like this. The right and left are transposed here. You can see this is the right temporal lobe looking relatively normal here, and what you can see here is an enormous amount of tissue loss on the left-hand side. And if we look at a different kind of a cut, here again in another patient, the right temporal lobe looking rather normal, the left temporal lobe having lost a lot of tissue, this darkness around it indicating tissue loss. So whereas patients with Alzheimer's disease lose the ability in the early stages to remember things from day to day, their day-to-day memory declines, what patients with semantic dementia lose rather is their conceptual knowledge. It's a rather astonishing idea, but that is what happens progressively over time. They lose their ability to know what things are, and they lose that ability irrespective of how you test them. If you ask them to name a picture, if you ask them to provide a name to a description, if you ask them how to use the thing, if you ask them what color the thing is, if the concept is lost, their knowledge of that concept will be lost. So they do very badly with single word comprehension. Unlike stroke patients, All of the patients with this condition have a very similar lesion, so it's a very predictable thing in that way. And once they've got that lesion, the way that they perform is also very predictable. So they have a high degree of sensitivity to items that are less frequent in their vocabulary and in the general vocabulary, and that are less familiar. So for example, a dog and a horse will be more enduring concepts for them than things like a camel or a hippopotamus. And because of that, they make rather systematic errors, again, quite unlike stroke patients. Often, if you show them an unusual animal like a kangaroo, what they will give you is a more frequently occurring item in the same category, like a dog or a goat. Or they make superordinate errors, that is to say, they tell you the category, oh, it's an animal, but they're not able to distinguish between exemplars. And there's a lot of consistency within a patient, so that once the concept is gone or is disintegrating for a patient, over time, more and more of that concept will be degraded. They won't behave inconsistently the way that stroke patients often do. Nevertheless, they're able to produce syntactically accurate, acceptable sentences. Their phonology is intact, their visual and visuospatial processing intact, and in general, they seem quite ordinary. So I want to tell you now about a particular patient to demonstrate this remarkable phenomenon to you. He's a man I saw quite a long time ago in Australia. At the time of his presentation, he was 56. He was a policeman, which he'd been for 30 years, but he was also an amateur cartoonist who'd been much published. And I think I've got... So here's one of his cartoons from before he became unwell. A child showing a mother a deconstruction of Thomas the Tank Engine. Here we dissected Thomas the Tank Engine and discussed the ergonomic practicality over the iconic influences. I want you to notice, first of all, that his language is very rich and sophisticated, that he's witty, and also that he's quite a good draftsman will become relevant for what I'm going to show you in a minute. So when he came, he said, about a 1 to 2 year history of difficulty with word finding in daily life. In his office, he had been the resident sort of walking dictionary and thesaurus, the person to whom everybody turned when they were looking for a word. But over this recent period, he'd become the butt of office jokes because he'd lost his ability to do that. So initially, he attributed the difficulty to age. He thought he might just be getting on. There were some stresses in his family. And then, in the way that happens so often nowadays, there was a workplace restructure and everybody had to apply for their own job. He did very well on the written component of the test, but when it came to the interview, much to his own shock, really, he absolutely failed, and he was not reappointed to his post and immediately sought medical investigation. So I'm going to show you now a video of this man. This will be live streamed, but I have asked for it not actually to be recorded, and if anybody is recording, I'd appreciate it if you didn't record the interview. Of course, at the time he agreed to the video and for its use. It's quite a while now since he died, but needless to say, there will be family and one needs to be sensitive about these things. So one of the ways that neuropsychology works is to think about not just that people are having difficulty or that they're making errors, but whether there is something about the errors that tells you something about the way that the cognitive domain is declining. So I've suggested that in these patients, the errors predominate on items that are low frequency, that is, infrequently occurring in the general culture, and that are less typical for their categories. So they are the items that usually the patients will have most difficulty with. And they'll have the difficulty because of the degree of the amount of semantic knowledge, as it were, the specificity of the semantic knowledge that's needed to be able to discriminate those particular exemplars from a category. So what we can see in these patients is that their performance on those tasks declines in a very predictable way over time, and that's what I want to show you now. in some of the tasks that he did. So this is a task that we call delayed copy drawing. Here, he's shown a line drawing of a peacock. He's shown it, and he's allowed to look at it for about 10 seconds, and then it's taken away from him, and he's asked to count backwards from 10, and then to draw what he's seen. He doesn't actually have to name it. He doesn't have to do anything except draw what it is that he was looking at. And it turns out that even for a task like that, you're rather dependent on what you know about the thing that you've been looking at. So what we've got here is that he remembers that it's a bird. This is a kind of a bird-like head, and it's only got 2 feet. And he knows that there's something goes on in its tail, but this is already starting to disintegrate fairly significantly. This is a man who would have had no difficulty drawing this creature, one can tell from the drawing that he does in his cartoons. And over time, this just gets more, the category becomes more and more deteriorated and kind of the item becomes more and more deteriorated and regresses to the category. So this is a year later. Now the head has lost all its bird-likeness and it's a kind of a generic animal head. Still only got 2 legs, although it seems like he's not quite sure whether that's right. There's something still going on, a bit unusual at the back end, but now it's just beginning to look like it might be a tail rather than feathers. And this, at the final round, this rather macabre, generic animal-looking creature, actually now with 4 legs, something on its back that he remembers that he's seen, and an actual tail. So at this final round, even though he's seen this thing 10 seconds before, he clearly has absolutely no idea at all what it is that he's seen, and having no semantics for it, isn't able to represent it even 10 seconds later. And you can see the regression to the kind of core features of a category. If you look here at his drawing of a rhinoceros, a goat, a swan, and a crocodile, the last time that we saw him, all of them have a kind of generic animal characteristic, 4 legs, a head, and a tail, but the swan also now falls under that rubric, and none of them look very distinguishable from one another. So that's all I want to show you. I wanted really to demonstrate to you the way in which neuropsychology is used, both, as I say, to analyse how cognition declines in patients and in other conditions in different ways, of course, but also then how we can use that information to think about how those domains are constituted in a normal brain. Thanks for your attention.